Quickly here, hepatitis B. Now we get into more chronic users and hepatitis B. Obviously, there is going to be vaccination involved. And in immunology and microbiology, you've covered these topics further. What I'm going to provide to you is more of a clinical background for each one of these viral hepatitis. 400 million worldwide. Obviously, you need to know this quite a bit. DNA virus with incubation. You need to know that hepatitis B is a DNA virus. Last time we talked anything about this, at some point in time, is that there's every possibility in chronicity. Two major chronic viral hepatitis that are important for you and I for pathology and cancer will be hepatitis B, which is a DNA virus, and hepatitis C, which would be an RNA virus. It's important that you know what kind of molecular goes on to cancers. Transmission here, parental or sexual routes. High risk of vertical transmission. What does that mean to you? You're thinking about a pregnant lady that is now giving birth, and during delivery, there's every possibility that through the vaginal canal, there might be vertical transmission, unfortunately, to the newborn. Think of this as being part of your torch. Hepatitis B. Leading risk factor for liver cancer worldwide. Also, keep in mind hepatitis C, and make sure that you know how to identify your hepatitis B or C. This is a DNA virus. Only 5% of adult infection develop chronic hepatitis, with the majority of perinatal infections are chronic. So there are two populations here. Very rarely do adults go on to chronicity. That'll be more hepatitis C. C in hepatitis C. C for chronicity. However, could you move on to chronicity in hepatitis B? Sure you can, but a measly 5%. Still important though. Now, if it's childhood vertical transmission, that's a little bit, that's difficult. That's more challenging, and there's every possibility or likelihood of a child going on to chronicity. Clinical presentation of hepatitis B, symptomatic disease, more severe than hepatitis A, hence we're going to elaborate on it further. Jaundice rarely lasts greater than 4 weeks. So you're thinking about, if you find jaundice in a patient with hepatitis B, you're thinking about, well, this must have been a timeline of approximately 1 month. 1% incidence of fulminant hepatitis, thank goodness. Move on to extrahepatic manifestations of hepatitis B. Here you do want to pay attention to the following. Angioneurotic edema. This is important. 30% of your patients, this patient may come to you and may complain of, "Ow, doc, my tummy hurts." And also you notice that there's blood in the urine. And you find that upon serology, you find an increase in ALT. Wow, that's interesting. The liver is involved, and I'm finding abdominal pain, and I'm finding hematuria. Should be thinking about polyarteritis nodosa. 30% of your patients with hepatitis B might actually be suffering from polyarteritis nodosa. These would be adults for the most part, and the two symptoms that I gave you, hey doc, my stomach hurts, the abdominal region. Radiate to the back, no, nothing like that. And I'm finding hematuria. So you need to make sure that you're quite astute with paying attention to your patient with such symptoms. And when you say polyarteritis nodosa, obviously this is a vasculitis. The vascular system that is being affected here would be the mesenteric blood vessel. What does that vasculitis mean to you? Inflammation of your blood vessel until there's occlusion, lack of blood supply to the abdominal region, mesentery. Anytime there's ischemia, how's the patient feeling? Pain. So pain in the abdomen. In addition, you have the renal blood vessels might start undergoing microaneurysms and may result in, as I told you, hematuria. Keep that in mind. Spend a second on polyarteritis nodosa and its association with hepatitis B. Also, association with MPGN, membranoproliferative glomerulonephritis. So what does this mean to you? MPGN, what kind of symptoms? Is it strictly nephritic? Is it strictly nephrotic? Or is it both? Both. So there might be hematuria and hypertension, and there might be also massive edema. And greater than 3.5 grams of protein loss. Allow for each one of these symptoms to give you amazing information for a particular condition so that you can choose the correct answer. Stick with me and I will get you there. MPGN, nephritic nephrotic, type 1, much more common than type 2. Now we can move on. Mononeuritis multiplex. That's interesting. Mononeuritis multiplex, what does that mean? One nerve that's being affected, an inflammatory process, in multiple organs. Maybe it's a radial nerve that's affected, wrist drop. Maybe it's the common peroneal nerve, foot drop, just as an example. One nerve in which it may affect multiple systems, resulting in the sequelae that you'd expect to see. Important here as well, cryoglobulinemia. This is more so found in hepatitis C. I will tell you that right off the back. If it's any type of viral hepatitis that you're worried about with cryoglobulinemia, what does that mean to you? Allow the name to speak to you. Cryo means cold. Upon exposure to cold, because of the immunoglobulins that are involved in viral hepatitis, that upon exposure to cold, the globulins will do what? Oh, yes, they will then precipitate, right? When they precipitate, this is then referred to as being your cryoglobulinemia. During cold conditions, it then aggregates or precipitates. Interesting. So 2 major cold issues that you want to know for your boards and your wards. When you're cold and you find that the fingers are now cyanotic, that's Raynaud's, or if you find cryoglobulinemia, cold. And oftentimes, whenever you think about or you hear about a patient in which there's ascending paralysis, it's preceded by an infection, and usually viral, Guillain-Barré syndrome. As I told you, what our focus will be here with hepatitis or viral type will be diagnosis. So let's begin.
Now we will move on to hepatitis B. As you can notice on this slide, the x-axis represents the time after the exposure to the virus, while the y-axis depicts the titer of the antigens and the antibodies that occur in response to infection. The first antigen to rise in hepatitis B infection is the hepatitis B surface antigen, HBsAg. This usually appears 1 month after exposure to the virus, sometimes even before the development of symptoms. HBV DNA can usually be detected during the same period as you can see on the graph. The hepatitis B E antigen, HBeAg, will most likely be positive in patients suffering from acute hepatitis B. When positive, this indicates greater risk of transmissibility of the virus. Anti-HBe represents the antibody against the hepatitis B antigen, and when it appears, it is an indicator of low infectivity. Another important antigen is the hepatitis core antigen, HBcAg. This is not depicted on the graph because this antigen is not detected in the blood of patients with hepatitis B. What we can detect, though, is the antibody against this antigen called anti-HBc, IgM or IgG. The IgM antibody against the core antigen usually appears with the onset of symptoms. While the IgM antibody levels fall, the IgG antibody is indefinitely positive in individuals with past hepatitis B infection. The antibody against the surface antigen, anti-HBs, appears weeks after the disappearance of the surface antigen. The period between the disappearance of the surface antigen and the appearance of the antibody against the surface antigen is called the window period. During this period, only the antibodies against the core antigen can be found in the blood.
Interpretation of your table here. This is once again for your hepatitis B specifically. That's your topic for the entire table. And on the top are the different type of components of hepatitis B, depending as to what's going on with your patient. Let's begin with interpretation at the far end of the table. And your focus would be acute infection or perhaps reactivation. So which one of these markers are you going to find? Early, acute. Hepatitis B surface antigen, I told you, shows up quite early in the symptomatic period. Anti-HBs, no, negative. That shows up later on. In order for this table to make perfect sense, I would recommend that you go back and take a look at the graph that we just discussed so that you have a visualization as to the journey or the time course of hepatitis B, and you also have a table in which it speaks to you. And then listen to me so that we can all reinforce this information, and at some point in time, it'll come back to you very quickly. We have anti-hepatitis B core, IgM. IgM is the first immunoglobulin to show up, thus positive in acute. And we have hepatitis B E antigen. This DNA, if at all possible, you'll find this early. This represents acute. Understood? Let's go on to prior infection with immunity. If you're thinking about prior infection, what kind of immunoglobulin should you be jumping to? Good, IgG. You'll notice here that anti-HBC, IgG, is positive. That's what your focus should be in prior infection. Why? Anytime there's prior infection, the type of immunoglobulin that you are then going to have chronically will be IgG. Obviously, anti-HBs will be positive. HBe may or may not be found, but your focus here should be on IgG. What about vaccination with immunity? Well, with immunity and vaccination, you still might find anti-HBs. That's way down the line. That then represents vaccination. Let's do chronic HBV. This is a carrier patient. Carrier. So what is the patient now carrying? It'll be HBs, as you can expect. What kind of IgG, or what kind of immunoglobulin? It will be IgG for hepatitis B. And here, the carrier, notice you have anti-HBe. And here the viral count, or HBV DNA, will be less than 20,000, 20K, but not as high as what you find in acute, but still present. Why? Your patient is in a state of chronic carrier state. Next, we have E antigen positive chronic hepatitis B. And this to you is dangerous. You find a couple things here. Your focus should be once again IgG and hepatitis B surface antigen, same as what you found earlier with chronic carrier. Here, there's going to be an E antigen present, but this is difficult for the patient and for you because you have a great number of HBV DNA. Active, extremely. Chronic, yes. E antigen, not good in terms of whether or not the patient is able to pass it on to his or her partner. And finally, we have E antigen negative, chronic hepatitis B. The only thing that you find here is the fact that you have anti-HBe. So this, at this point, is E antigen negative. In terms of viral count, it'll still be greater than 20,000. Interpretation is where your focus should be at first. Then you take a look at the various markers, you interpret as such, and then go back and take a look at the graph in which you're able to understand the timeline. Let's talk about management for hepatitis B. We have interferons for hepatitis B. We have PEG interferon. We have interferon alpha. That's important. Please memorize the alpha for hepatitis B. And limited duration of therapy, high side effect burden is what you're worried about, especially with interferons. Management continues, and we have antiviral drugs such as lamivudine, resistance oftentimes seen. We have entecavir, adufavir, tenofovir. Stop there. You'll notice we have the suffix vir. Your focus should be on viral hepatitis, specifically B, and we have VIR, virus, usually indefinite therapy concern, but the only thing is you are worried about resistance in this patient with hepatitis B. Antiviral drugs that you want to be familiar with. Obviously, your focus should also be on prevention. Let's begin the vaccination. The vaccination therapy and the regimen is something that you want to be very familiar with coming off of immunology. If you're not, it would be a good time to go back and make sure that you take a look at vaccination regimen for hepatitis B specifically, please. Perinatal exposure, universal vaccination for all children. Now, whatever your personal belief would be on vaccination, at this point, you keep that to yourself. I highly recommend that. Healthcare workers, hemodialysis patients, IV drug abusers, persons with recent exposure, and patients with chronic liver disease. This is your population in which you need to make sure that you prevent hepatitis B from developing.